Good morning, everybody. Welcome to the Ceylon College of Physicians Young Physicians Forum, where we showcase our associate members, senior registrars in medicine and allied fields. We have two interesting talks today. The first is by Dr. Sahathevan Vithoosan, who is a senior lecturer in neurology at the National Hospital of Sri Lanka, who will speak on an unusual CNS infection, a ticking time bomb. And after that, we have Dr. Pravinson Mohanaruban, who will speak on blood pressure control in patients with chronic kidney disease. Dr. Mohanaruban is a senior registrar in general medicine at the teaching hospital Jaffna. We will start with the first talk by Dr. Vithoosan on an unusual CNS infection, a ticking time bomb.
Good afternoon. Thank you, sir, for the introduction, and I want to thank the college for this opportunity. My topic for today is an unusual CNS infection, a ticking time bomb. And for the next 25 minutes, I want to highlight how high degree of clinical suspicion and vigilance in a clinical setting can prevent this tragedy from happening. I'll first describe 3 cases which I came across over the last few months, followed by theory discussion. My first patient is a 48-year-old. Note he's a previously healthy man. He's a postman. He has presented with a right-sided upper limb pain for 1 month duration. Within a short time, he developed right-sided upper limb and lower limb numbness. Gradually, he has developed weakness on that side. Within a few days after admission, it has progressed to bilateral upper limb and lower limb weakness. Basically, he is quadriparetic. There was bladder and bowel involvement. He developed recurrent hiccups after admission. There was also a history of neck pain for the last 2 months. He did not have any history of fever, past history of tuberculosis, or constitutional symptoms like loss of appetite or loss of weight. He did not have any history of malignancies, so there was no past history suggestive of transverse myelitis or optic neuritis. Coming to the examination, the general examination was normal. There was no neck stiffness. GCS was 15. Cranial nerves were normal. Eye movements were normal. Fundus was normal. So coming to the upper limb and lower limb examination. So if you look at the upper limb examination, there was a bilateral weakness, mildly asymmetric. The tone was reduced. The reflexes were reduced. Coming to the lower limb, he was basically the power 0. He was basically in a spinal shock stage with a reduced tone and reduced reflexes with the upgoing planters. There was a sensory level of T4, which we thought is a false sensory level, and the cerebellar signs were negative. So this is basically a man with quadriparesis with a sensory level. So coming to the investigation, look at the investigations first. The full blood count and the inflammatory markers were normal. So we had done the first lumbar puncture, the CSF. There was a mild increase in the protein. The sugar was 72. There was some amount of sugar drop compared to the random blood sugar, which was 159 at that time. And look, very importantly, the CSF cells were acellular. There was no cells, basically. So the further oligoclonal bands and TB gene expert was negative. So we went ahead with an MRI. You can see, actually, I think you can see a long segment myelitis here. It is extending throughout the cervical cord, going up to the brainstem, and it was reported as a long segment myelitis from C1 to C7 with a spinal cord edema, and there was an extension to the brainstem as well. So with this, this was a normal CSF with a mild increase in the protein. There was a long segment myelitis in your MRI. So all the diseases like demyelinating conditions like NMO spectrum disorders will come on top. So we started the patient because ESR, CRP, normal, the cultures were negative. So basically the infective causes seems unlikely. So we started him with a methylprednisolone pulsing. 5 days, there was no improvement of the symptoms. He gradually worsened. Subsequently, he underwent plasma exchange for 5 cycles. So during this time, he developed 2 episodes of high fever, which was attributed to the line sepsis and managed with antibiotics. So since he has not improved, we went ahead with the second imaging. We have again done the MRI of the spine, the pan spine with the brain. Again, there was worsening of the MRI. There was a long segment myelitis. Now throughout the spinal cord, there's a significant cord edema, and it was being reported as a possible infective process which is involving the whole segment of the spinal cord and the brainstem. And very important, just note down these, there was an involvement of the corona radiata as well. They have carried a possible abscess formation as well. So these are the MRI images. So with this, we are going ahead with the second lumbar puncture. You may remember the first LP, there was basically it's an acellular LP, other than the fact there was a mild increase in the protein. But if you look at the second LP, it has completely changed. There was a very high increase in the protein. There was some amount of sugar drop. It's very cellular. Lymphocytes were 1,600. Polymorphs were 10,200. And importantly, the adenosine deaminase in the CSF was 26. So when it comes to adenosine deaminase, even though the adenosine deaminase levels in the CSF has not been studied to the extent like it is studied in the pleural fluid, but when the CSF ADA is above 15, it is more and more suggestive of TB. So by the time it comes to 2025, most of the people say it is more likely TB. So with this high degree of suspicion, this patient was started on anti-TB drugs. So later, after about 1 to 2 weeks, we are getting the CSF culture, which had been positive for Burkholderia pseudomalacia meliodosis organism, but the antibody titers were normal at that time. So when we went back and analyzed the images again, I'll come back to this point again later in my discussion, the MRI brain also showed there was a trigeminal nerve enhancement bilaterally, which was found in the MRI brain. So the patient was managed with IV meropenem and cotrimoxazole in the initial intensive phase, followed by cotrimoxazole for a long duration, more than 6 months here in this case, but he had poor clinical recovery despite mild improvement in the neuroimaging. So coming to my second case, like my first patient, my second patient, she is a previously healthy female. She was perfectly normal before that. She again came with a bilateral lower limb weakness like my first patient. So it was initially started as a left lower limb weakness, followed by a right lower limb weakness with a bladder and bowel involvement. The upper limbs were normal, vision was normal. There was no preceding history of infections or vaccinations. So again, the examination revealed a flaccid paralysis in a spinal shock stage with the upgoing planters, reduced reflexes with a sensory level of T2. So again, it's a spinal cord pathology. The upper limb was initially normal. So coming to the full blood count, it was normal. Inflammatory markers, ESR was high. The CRP was normal. So we have gone ahead with the CSF analysis. There was a mild increase in the protein, no significant sugar drop here. The lymphocytes were high, ADA was normal, the TB gene expert, cultures, and CSF oligoclonal bands were negative. So we proceeded with the MRI. Again, it showed a long segment myelitis extending from the T3 to T7 level. There had been some cystic areas which was noted in the T9 to L2 level as well. So these were the MRI. You can see the long segment myelitis in the thoracic and the lumbar region. So these are the other MRI images. So now we are vigilant because we had an experience from our first patient. So even though we thought about the TB, other infective pathologies, other demyelinating conditions, so meliodosis was back in our mind because of the experience we have already gained. And we checked the meliodosis antibodies, so it was found to be very significantly high, 1 in 640. So this patient was treated with meropenem with oral cotrimoxazole, but she had an excellent response with a near complete resolution of the MRI changes. So far, I have shown you 2 cases of long segment myelitis. Both were supposed to be due to meliodosis, but the first patient had a very bad outcome despite treatment. The second patient had a very favorable outcome. So coming to the long segment myelitis is a traditional list we go across whenever we have a patient with a long segment myelitis, starting from the NMO spectrum disorders, going on to autoimmune diseases like SLE, Sjogren's, Behçet's, sarcoidosis, sometimes multiple sclerosis, and B12 deficiency, etc., etc. But what I want to highlight now, I think it's now time to add melioidosis also to this list of long segment myelitis, at least in these endemic regions. So coming to my third case, my last case I want to show here, this is a 70-year-old female without a history of diabetes. But when we went back and asked the history, there was a possible exposure to paddy field. So she had a background, 1-month history of fever, constitutional symptoms. She again came like our second patient with a right-sided upper limb numbness, which has progressed to weakness of the upper limb and lower limb. And then there was a drop in the GCS over 1 day duration. So examination, she had neck stiffness, and there was a right side face arm leg weakness. So inflammatory markers and full blood count was normal. If you look at the CSF, their protein was 142. Look at the sugar. There was a significant sugar drop. Our traditional teaching, or what we have experienced up to this point, when there is a significant sugar drop with this background, TB comes on top. The lymphocytes were high, polymorphs were 2 polymorphs, ADA was normal, and TB gene expert was negative. The MRI, this patient had multiple ring-enhancing lesions. It was involving the internal capsule, globus pallidus, coronal radiator. So they have given the differential diagnosis of TB abscess and CNS melioidosis. And this patient was initially started on ATT. Then actually after 2 weeks, the clinical response was not good. So we went ahead with the second lumbar puncture. There was a partial improvement if you look at the CSF reports. Protein has come down, cellular reaction has come down, the ADA and those things were normal. Interestingly, in this patient also, the antibodies were positive, 1 in 640. The patient was started on treatment for melioidosis with an excellent response. So coming to this melioidosis, I just talk about melioidosis in general to start off with. The melioidosis, which is called Whitmore's disease, you all know this Burkholderia pseudomelae is a gram-negative, facultative, soil saprophyte. This is responsible for this melioidosis. It is contracted through the inoculated soil or water, but it can also spread by the inhalation, and particularly common in this part of the world after the wet season. So I want to highlight this point because if you remember the 3 patients I have shown you, they did not have evidence of melioidosis anywhere else. So one of the postulated mechanism is during inhalation, it can spread through the cranial nerves, like olfactory nerves. So that's one of the mechanisms which they are postulating for the pathogenesis. It was first described in 1912 by Captain Alfred Whitmore and his assistant Krishnaswamy. It is thought to be endemic in the Southeast Asia and the melioidosis belt, and Sri Lanka is also supposed to be endemic for this condition. So melioidosis has a wide range of presentation, as you all know, starting from the pulmonary infections, genitourinary infections, bones, soft tissue infections, severe sepsis, and neurological complications. So coming to melioidosis in Sri Lanka in general, Sri Lanka lies in the melioidosis belt, which is 5 to 10 degrees north of the equator. We are falling there. Interestingly, we are one of the very few countries who reported new melioidosis at the start. After the first description in 1912 in Burma, then a few reports from Vietnam and Malaya, the current Malaysia and Singapore, we were the 4th country to report melioidosis. But however, after the initial description in 1927, we didn't have any reports for the next 7 decades. Then in the early 2000s, this has emerged again. So as a result, this national surveillance program was initiated in 2008, and there had been 250 cases of culture-positive melioidosis, which was described from 2006 to 2017. So out of these 250 cases, which has been described here, the CNS melioidosis was about 5%, which was falling with a range what is observed in the other parts of the world as well. So we have seen meningitis, subdural empyema, cerebral abscess, brainstem encephalitis, transverse myelitis, Guillain-Barre, and status. So coming to my presentation today, the neuromyelidosis, even though it comprises only 4% of the melioidosis, it is significantly important because 25% will die irrespective of the management, and the survivors have a significant morbidity. So it can mimic Guillain-Barre, it can mimic transverse myelitis, and they can present with cranial nerve palsies. So if you look at the symptoms, the fever is the most common presentation, followed by altered consciousness, headache, neck stiffness, seizures, paraplegia, quadriplegia, cranial nerve palsy. Majority of the patients fall into acute melioidosis category. They come within the first 2 months of onset. So these are the countries where the CNS melioidosis has been described. This is basically the melioidosis belt, right? This is about 5 to 10 degrees from the equator, right? So these are the symptoms, right? In addition to the headache, altered consciousness, neck stiffness, the cranial nerve 7 nerve palsy, the facial nerve palsy is commonly described here. The next important point, like our tuberculosis, this Burkholderia pseudomelae can remain latent for an extended period. So if you go back to the literature, it has been called as the Vietnam time bomb because it has been described after years, about 10 to 13 years later, in the American soldiers who served in Vietnam during the Vietnamese War. So if you look at the risk factors for melioidosis, we all know the immunosuppressive conditions, diabetes, alcoholism, renal disease, immunosuppression, etc., are risk factors for melioidosis. But my message to you, if you go through the 3 patients what I have described, they didn't have the traditional risk factors for melioidosis. So the important thing is when it comes to CNS melioidosis, the traditional risk factors what we see in the rest of the melioidosis may not be there. So if you look at the MRI finding, they can have the calvarial osteomyelitis, leptomeningeal enhancement, ring-enhancing lesion, abscesses, brainstem involvement, etc. So if you look at the radiological findings of melioidosis, this is not specific, so it can mimic the TB and arboviral infections as well. So the pathogenesis of melioidosis, if you go through the initial case reports, most of the case series in melioidosis has come from Australia, Darwin, and Southeast Asia, Thailand, etc. So initially, the pathogenesis was thought to be an exotoxin-mediated phenomenon, but later, with the advancement, it was thought to be direct invasion of the bacterium as the responsible mechanism. So there are 3 ways this bacteria enters or bypasses the blood-brain barrier, either in a transcellular route, paracellular route, or like the Trojan horse. It survives inside the monocytes, and with that, it passes the blood-brain barrier. So coming to the diagnosis, the sensitivity or the antibody is just 50%, is 56%. So if you look at the CSF in the neuromyelidosis, they are having mononuclear cells that traditionally in the history, they have been described to have high protein and normal sugars. So this is one of the points I want to highlight, because if you look at the patient, what I have shown, there was a significant sugar drop. Because this is very important because the TB comes hand in hand with this. What we see is we see TB very common. So just because there is a sugar drop, it does not always mean it's TB. We have seen enough patients with a significant sugar drop with melioidosis. Just keep in mind, so even though to sugar drop favors TB, just make sure it is not melioidosis. So the diagnosis is made by the isolation of these organisms from the brain tissue, pus, or culture. So if you look at the imaging findings, it has a propensity to spread through the white matter tracts, so it can extend along the tracts and longitudinal fibers. The registrars who are listening to these, so keep this point in mind, not only in your practice, but also in your exams, in the grades and etc. This is one of the facts that might tells you this is probably a CNS melioidosis, so which may be a point which will help you to differentiate this from tuberculosis. So coming to the treatment, the ideal regime is debatable. So I'll just talk in common. We all know when it comes to the management of melioidosis, we all know there is an intensive phase followed by an eradication phase. So if you look at the intensive phase, the whole purpose or the main purpose of the intensive phase is to prevent the mortality and disability. If you look at the eradication phase, the purpose of the eradication phase in melioidosis in common, I'm not talking about the CNS melioidosis only, is to prevent the relapse. So we all know when it comes to the intensive phase in melioidosis, there are 2 options which are commonly used. One is the ceftazidime, or the other one is the carbapenems, meropenem, imipenem, etc. There are no head-to-head trials comparing these 2. Actually, one study which was started in Thailand, it has been stopped in halfway. But it has been, in general, it has been accepted to start meropenem instead of what you say ceftazidime when it comes to severe melioidosis and CNS melioidosis. It based on the fact this meropenem is giving a post-antibiotic effect after the initial dose. The effect lasts for a long time is one point. The in vitro activity is better. So there was a general consensus that meropenem will be better than ceftazidime when it comes to the intensive phase. The second question, are we going to give meropenem only like what we are doing in our normal other cases of melioidosis, or are we going to combine with cotrimoxazole? Again, there is no clear answer, but again, there is a general consensus. Basically, most of these reports have come from Australia to add cotrimoxazole because it is increasing the CNS penetration. So this is used for the intensive phase. Coming to the continuation phase, eradication phase. So at least we are giving 6 months here. I'll come back to this again. So the options available, you may all remember that even in general melioidosis, one is this cotrimoxazole, other one is doxycycline. Whether there is a place to combine cotrimoxazole with doxycycline or cotrimoxazole alone, There was a MERT study which was done in Thailand, so where they found cotrimazole alone is equally effective to cotrimazole plus doxycycline. But remember, this MERT study is a general study which was done in meliodosis in common. If you go back to this MERT study and analyzed, the MERT study which has involved about 600 patients, but if I'm right, there was only 3 cases of CNS meliodosis in that case. So usually the preferred regime is an IV meropenem with a cotrimazole, depending on your practice, what you're having on the part of the world, or your local practice, at least 8 weeks of intensive phase, which is followed by 6 months, minimum 6 months of an eradication phase is recommended. So this is the duration for each and everything. You can see this meliodosis, CNS infection is one of the infections which we are treating for the long time. So these are my references, and thank you very much. And I'm happy to answer any questions.
For that interesting presentation. There are a couple of questions from the audience. One is, can you get false positives with melioidosis antibodies?
It's possible, sir. Obviously, it's possible because this is an endemic region. We might have been exposed to this organism. So, but having said that, with the clinical picture, if the antibodies are significant, it is supposed to be taken as meliodosis. So, even though TB is one of the differential diagnoses. So, the next thing is, it's a very good question. There is a possibility we can check the antibody titers, is a second point. The third point I want to highlight is just because the antibodies are negative, again, it does not exclude meliodosis. Because especially when it comes to CNS meliodosis, most of the cases, antibodies can be negative as well. So there have been reports where the CNS meliodosis was diagnosed with antibodies of 1 in 40, because one of the reasons they are postulating is when the patient comes early, the antibodies can be there. Zero conversion has not happened. So even though it's possible, because since Sri Lanka is considered to be endemic, to have a previous exposure which your antibodies are there, but again, I don't think we have a study which is saying how long these antibodies will last. But with the appropriate clinical context, I think we have to take that as significant.
Is there a cutoff titer for antibodies?
Not really. Not really.
So what would you consider a positive titer?
Actually, in our first patient, the patient's culture has become positive.
Yes.
Even though the antibody was 1 in 40. 1 in 40. So if you look at the second patient, the antibodies were 1 in 640. 1 in 640. So it was obviously significant. So we don't have a cutoff like above this is meliodosis or below this is excluding meliodosis. But if it is high or if it is rising, it is considered to be significant.
Just the thing about the antibodies, can you measure the antibodies in the CSF? Is that done?
It can be done.
Is it practiced or is it?
I don't think it's practiced, but I think the Australian reports they have measured.
They have measured.
Yes.
There is one other question. Did a follow-up MRI show improvement in the patient with the brain abscess?
Not really. Actually, that patient had there was a mild clinical improvement. Yes. There was a mild imaging improvement without any clinical improvement.
I have one more question. The Guillain-Barre syndrome that you mentioned.
Yes.
Did the first patient have Guillain-Barre or was it a transverse myelitis?
It's a transverse myelitis. It's a long segment myelitis.
So the Guillain-Barre, is it immune mediated or is it direct damage?
Actually,
it's likely to be immune mediated.
It's likely to be immune mediated.
Is there any evidence on that, on whether you can get immune manifestations as a result of melioidosis?
Well, I think we are having one Sri Lankan report where they have reported the first case of transverse myelitis. Even for transverse myelitis, they have postulated the immune mediated mechanism because it can occur like after any other infection. So similarly, I don't think there is evidence to say the particular antibodies or anything, but the pathogenesis in Guillain-Barre, because there is no evidence of direct invasion, there cannot be an evidence of direct invasion. So it is, it's postulated to be immune mediated.
What about transverse myelitis? Is that due to direct cellular toxicity or is it?
Actually, sir, that's what I pointed out in my first case. In my first patient, the transverse myelitis, it was thought to be direct invasion because the CSF culture was positive.
Right.
So even though the initial thought was it can be a toxin mediated, now the current thinking is it is more in favor of a direct invasion rather than a toxin mediated or immune mediated.
Are there any other questions from the audience or from those online? If there are no other questions, I have a question, but unless Anyone else? While they are waiting for the questions, may I ask, is there a PCR?
PCR is there, sir. Yeah. PCR
Do you use the PCR? Did you use the PCR on the CSF on these
We
patients?
have not used the PCR in this patient, but it is done. I think most of the work on this has been by Professor Jennifer Pereira. She has actually came up with an article in Meliodosis in Sri Lanka. So they have talked about different strains because the PCR is important because sometimes, so when a patient with a meliodosis comes with a second attack, so there are two questions to answer, whether it's a relapse or whether it's a reinfection. So one of the ways is you can look at the PCR and look at the strain, and you can differentiate whether it's a relapse or a reinfection, and that is available in Sri Lanka.
Have we got any more? Yes, please.
Yes, there's a difference. So CNS meliodosis, we are going for the intensive phase for at least, the intensive phase is given for at least 8 weeks, minimum 8 weeks. So again, coming to the CNS meliodosis, actually depending on the severity, so you can use the meropenem with quatrimoxazole. So there was if the patient's clinical condition is bad. Again, when it comes to CNS meliodosis, rather than ceftazidime, we'll prefer to give meropenem in CNS meliodosis. Again, coming to the eradication phase, the quatrimoxazole has been given at least for 6 months. Again, that if you look at the MERT trial, so they are talking about quatrimoxazole is equal to quatrimoxazole plus doxycycline. The effect is equal, side effects are more in the combination. But having said that, I think that is another thing we have to consider. Even in our first patient, at one point, we have added quatrimoxazole with doxycycline because of the poor clinical improvement. The trials which has been done regarding this eradication regime, like MERT trials or the other trials from the Southeast Asia and Australia, they have actually studied the meliodosis in common. So if we go ahead with their patients, actually the MERT trial has 600 patients with only 3 patients with CNS meliodosis.
Is there any problem in giving steroids now you said you treated with the pulse steroids for Guillain-Barre?
Not because of the Guillain-Barre, we actually
thought
about the transverse myelitis.
Yes.
And because of the CSF was acellular, and the inflammatory markers were normal, full blood count normal, your cultures are negative. So we thought rather than an infective cause, an inflammatory cause like the demyelination, NMO spectrum disorders might be more likely. That's the reason which made us to pulse and go ahead with the plasma exchange, thinking about the immune-mediated process, but actually that was not effective, and actually it can harm the patient possibly.
We have another question which I think you've already answered. Is there a place to look for a rising titer? You mentioned that there are probably...
you can keep on looking, because especially when the patient comes early, your antibodies can be negative, but it does not exclude the meliodosis.
There is one other question, Dr. Sufad, is there any duration difference for psoas abscess with melioidosis? I'm not sure what it means, what the question means. Is there a longer duration for treatment? Is that what you mean, Dr. Sufad? The question is there...
Answering his question, I think, I don't know, my screen is shared or not, I'm not sure. Actually, yeah, okay.
I think what is meant is the duration of treatment difference.
So if you look at these deep-seated collections, I think psoas abscess will fall into that, right?
Yeah.
So the duration is about 4 weeks when it comes to the intensive phase, followed by eradication phase of at least 90 days.
So you'd go for a longer course.
Longer course compared to the skin melioidosis or lung meliodosis.
But for CNS?
But it's shorter than the CNS.
Shorter than the CNS.
Yes, but again, these things may not be that simple in the real life, because most of the time these patients who are having a psoas abscess have some vertebral involvement with a secondary spinal cord involvement. So in that case, we may have to go by individual cases.
Any other questions from the audience? I think we've covered most of the questions. The steroids are not detrimental, are they? Or would you recommend standard?
No, sir. I'm not recommending. Actually, it is supposed to be detrimental because there's no
So you don't have to concurrently treat with steroids for CNS involvement.
We don't have to. That is the practice what we are using in TB.
Exactly.
But that's not the case here. There's no recommendation to use steroids. Maybe in a case-by-case basis, when you're having a significant edema or something, you may be using for 1 or 2 days, but not as a regime or the accepted treatment.
Right. I think that's all the questions. So that was a lovely presentation. Very interesting. And it's a rare condition also. I think Dr. Inokakure also does quite a lot of work on melioidosis.
So basically all the, I think we have come to know this much because of
Thank you. So Dr. Vithoosan, thank you so much for your interesting presentation. Thank you very much. We'll move on to the next presentation. Yes, are we ready, Nalini? Yeah. The next presentation is by Dr. Mohanaruban, General Medicine Senior Registrar, who is going to talk on the interesting topic of blood pressure control in patients with chronic kidney disease. Over to you, Dr. Mohanaruban.
Good afternoon, all of you. Firstly, I would like to thank the chairperson and the Ceylon College of Physicians to give me this opportunity. My topic is blood pressure control in patients with chronic kidney disease. We know the blood pressure control is helped to reduce both cardiac and renal events. However, we will see why intensive blood pressure control is still needed even we don't have a more renal benefit. The relationship between hypertension and chronic kidney disease is established with multiple studies, and there is a positive correlation between high blood pressure and events of end-stage renal disease condition. Long-standing untreated hypertension often leads to development of chronic kidney disease. This is called hypertensive nephrosclerosis. The changes are described here based on the histology. Glomerular changes are focal and global sclerosis with reduced nitric oxide level. Vascular changes are hyaline deposition in vessels lead to intimal thickening and narrowing. There are interstitial fibrosis and tubular atrophy. Chronic kidney disease, by whatever etiology, eventually leads to hypertension, which is caused by various complex mechanisms. These are endothelial dysfunction, sodium retention, increased renin and angiotensin levels with activation of sympathetic system. All mechanisms ultimately cause volume expansion and increased blood pressure. There are several minor factors also contributing to the hypertension in chronic kidney disease. There are erythropoiesis-stimulating agents which reverse the hypoxia-induced vasodilation, and secondary hyperparathyroidism, which increase calcium levels and which cause vasoconstriction. That is uremia. Uremia inhibits the nitric oxide synthesis and it increases the sympathetic tone, causing hypertension. And vascular calcification, which resists to the antihypertensive medication. And also, there are vasoactive substance imbalance, such as lack of renal prostaglandin and the prostacyclin, with increased endothelin 1, which causes vasoconstriction and the renal tissue fibrosis. As illustrated here, hypertension, cardiovascular disease, and the chronic kidney disease are interrelated, and treatment should focus all the risk factors at the same time. To begin with the blood pressure control, we need an accurate measurement. Standardized office blood pressure measurement is recommended for therapeutic purposes. Guidelines are recommended automated, either attended or unattended method using an oscillometric blood pressure device, like this, like we are using in the Omron in the clinic practices. Second step is setting a target blood pressure. Till this year, major guidelines suggested a lower blood pressure target for younger patients, mainly systolic blood pressure at less than 140 or 130 if tolerated, and for other age group is between 130 to 139. After starting the medication, some patients may reach targeted blood pressure at office level, but having elevated blood pressure at out of office. It is called masked uncontrolled hypertension. Masked uncontrolled hypertension had a threefold higher risk for the fatal and non-fatal cardiovascular event, and a nearly fourfold higher risk for dialysis initiation. This is highly prevalent among CKD patients. It's up to 70% in some studies. This phenomenon closely related to non-dipping of blood pressure in night. The non-dippers have sleeping blood pressure, which is not reduced as expected and even paradoxically elevated compared to daytime blood pressure, especially patients with high salt intake, impaired salt water clearance, and patients with obstructive sleep apnea. Those patients with non-dipping also have renal histological changes such as interstitial fibrosis and tubular atrophy. Chronotherapy could reverse the non-dipping nocturnal blood pressure seen in the CKD. Chronotherapy means adding antihypertensive drugs, especially in the night or evening time. For some patients, it's very difficult to achieve blood pressure targets with even 4 or 5 drugs. Such patients may have secondary causes for hypertension. But before considering those causes, we must re-evaluate the patient. Most of the time, wrong method of blood pressure measurement, poor adherence, poor lifestyle, and inadequate drug doses are responsible for that. After identifying the correctable causes, we can consider secondary causes for the true hypertension. There are endocrine causes, vascular causes, and several drugs contribute to secondary hypertension. Chronic kidney disease itself also a common cause. Blood pressure target for chronic kidney disease patients are further reduced according to 2021 KDIGO guideline. It largely based on SPRINT trial. In a SPRINT trial, higher risk for cardiovascular disease, intensive blood pressure control improved outcomes and overall survival compared to the standard therapy. Actually, there are two cardioprotective trials are there, SPRINT and the ACCORD. The ACCORD trial, there's a benefit, but there are no statistically significant. But SPRINT trial, there's a statistically significant results are there. Will amount of the proteinuria affect the blood pressure target? Here, different guidelines recommend almost similar recommendations regarding proteinuria. All guidelines point toward a lower blood pressure target, regardless of the proteinuria. KDIGO suggests targeted systolic blood pressure of 120 mm mercury or less is largely based on the SPRINT trial. But this recommendation not applicable to patients with fall risk, age more than 90, advanced stages of chronic kidney disease, and patients with renal transplant or on dialysis. It is also applicable to who are in the low diastolic blood pressure also. Polycystic kidney disease patients need more blood pressure reduction. It usually says even less than 110. So, any concerns about renal adverse effects on intensive blood pressure control? In the SPRINT study, acute kidney injury events were about 3.8% in intensive arm compared to 2.3% in a standard group. However, these acute kidney injury events were mild, transient, and not necessarily structural changes. Basically, they are saying it's due to the hemodynamic changes due to the drugs. Although there were no composite renal outcomes, KDIGO suggests low blood pressure target due to cardiovascular outcome and mortality benefit. And they agree that the intensive blood pressure does not bring more renal benefit, but they mainly consider cardiovascular benefit. Findings and recommendations of SPRINT trial are once strengthened by a newer Chinese STEP trial. Intensive blood pressure control among elderly population also reduce cardiovascular event, but no significant renal outcomes. And this, according to the STEP trial, the mean systolic blood pressure is between 110 to 130, even lower than the SPRINT trial blood pressure. They are also part of the normal patient as well as a chronic kidney disease patient, but there is no significant renal outcomes in an intensive arm compared to the standard. Why intensive blood pressure control is still needed when there is no more renal related benefit? In this first graph, cardiovascular events are more in patients with low EGFR. And as described in the second graph, sudden cardiac death is more in patients with end-stage renal disease patient on hemodialysis. Now focus on the management. Considering non-pharmacological management, we know low sodium diet, weight reduction, DASH diet, and exercise have benefits on blood pressure reduction. Interestingly, high intake of potassium also help to reduce blood pressure by reduce the vessel tone and increase the sodium excretion in urine. Please note, this is not advisable for patients with advanced kidney disease. Fewer studies have shown that low level of potassium related to increased risk of stroke and other cardiovascular events, such as MI. Regarding protein meal, red meat and its byproducts are causing harmful effect on the kidneys. Like carnitine production leads to atherosclerosis development, and there's a uric toxic generation, which causes inflammation, oxidative stress, endothelial dysfunction, muscle wasting, and renal interstitial fibrosis. But plant-based low-protein diet may constrict the glomerular afferent arteriole. Here, the constrict the glomerular afferent arteriole and having complementary action with RAS inhibitors and causes blood pressure reduction. Not only plant-based low-protein diet constricting the afferent arteriole, there's a Sglt2 inhibitor also, there is a role to constrict the afferent arteriole. And it has a complementary action with the RAS inhibitor, which is a vasodilation in the efferent arteriole. So ultimately, there's a renal protection. Now focus on pharmacological management. First line drugs are ACE inhibitor with either calcium channel blocker or diuretics. Loop diuretics are preferred when there is a fleet overload or reduced EGFR. For resistant hypertension, spironolactone and alpha-beta blockers are used. Consider beta blocker at any step where there is an indication. The most familiar drug class is RAS inhibitors, renin-angiotensin system inhibitor. This picture illustrates how these drugs are acting on various levels and receptors. Note that there are two types of receptors, angiotensin 1 and angiotensin 2 receptors. As we see here, angiotensin 1 receptor stimulation causes vasoconstriction and secretion of the aldosterone. Action of angiotensin 2 receptors are counteracting the actions of angiotensin 1 receptor like vasodilation and reducing the blood pressure. So which one is the better drug? AC inhibitor blocks both AT1 and the AT2 receptor, and in addition to that, there are increased level of bradykinin, which has vasodilatory properties. But angiotensin receptor blockers only block AT1 receptor, not AT2. So what do you think, which one is a better drug? But so far, however, available guidelines stress on AC inhibitor than AR blockers, probably the greater efficacy of the bradykinin. But this is also depend on few articles. There are no solid evidence which one is better yet. The recent studies have shown AR blockers have better blood pressure reduction compared to AC inhibitor. Trials have shown that AR blockers are non-inferior to the AC inhibitor. Efficacy and safety also slightly favor to AR blockers than the AC inhibitor. These are few head-to-head trials recently published in Journal of American College of Cardiology. If patient develops hyperkalemia, we must try other possible methods to reduce potassium level before considering withdrawal or reduce the dose of RAS inhibitors. Some measures are cut down the dietary potassium and the potassium supplement and using potassium wasting diuretics and the oral potassium binders. There is no randomized controlled trials on initiation, continuation, or discontinuation of RAS inhibitors at stage 5. It depends on physician's individual decision. Can consider discontinuation for hypotension, uremic state, and hyperkalemia. Combination in between these drugs causes increased adverse effects. Beneficial effect of RAS inhibitors based on progression of end-stage renal disease, reduction of proteinuria, mortality benefits, and the cardiovascular outcome. Next class is mineralocorticoid receptor antagonist. Mineralocorticoid antagonists are used to resistant hypertension and benefit in patients with diabetic kidney disease. Finrenone is a non-steroidal mineralocorticoid receptor antagonist. It recently guidelines are published about the efficacy. which reduces the primary renal outcome and the cardiovascular outcome. And if patients not tolerate spironolactone, we can use amilorate as a fourth medication for the resistant hypertension. It is important to mention that patients with metabolic syndrome have higher angiotensin 1 receptor expression, increased mineralocorticoid activity, especially if patient with obstructive sleep apnea, and increased sympathetic activity also. Next class is calcium channel blocker. Dihydropyridine and non-dihydropyridine drugs are widely used drugs among CKD patients because of minimal AKI risk. Diltiazem and verapamil have antiprotein uric effect, but that is not for amlodipine. Combination of amlodipine and verapamil decrease the blood pressure, but this is not a class recommendation in main guidelines. Do not use calcium channel blocker without combined with a RAS inhibitor for hypertension. Otherwise, it causes increased hyperfiltration and increased albuminuria. So, calcium channel blocker also has a wide range, and they also have renal and the cardiac benefit. Regarding diuretics, thiazide diuretics trigger volume depletion and vasopressin release, and this contribute to cyst enlargement in the polycystic kidney disease patient. So, it's better to avoid in such conditions. Clothianidone is more effective among black patients in reducing the heart failure, and it has a better profile compared to hydrochlorothiazide. Loop diuretics are better choice for reducing the fluid overload, and it can be used at any stage in the chronic kidney disease. It usually combined with thiazide diuretics and mineralocorticoid antagonist. This combination is called sequential nephron block. This combination ensures the sodium resorption block in different areas of the nephron. For a full sequential nephron block, we must combine loop diuretic, thiazide diuretic, spironolactone, and amilorate. So, according to this diagram, we can see how the diuretics classes are switching between the EGFR status. At initially, there's a thiazide diuretics, but when EGFR reduces, we can 4th and 5th stages, loop diuretics come to place first and followed by a thiazide diuretics. For a theoretical or some experimental studies at stage 5, we can use thiazide diuretics, but with a large dose, like 50 milligram BD or 100 milligram BD. So, different classes of diuretics have different adverse effect. Loop diuretics causes ototoxicity, and thiazide diuretics causes hyponatremia and hyperuricemia. Beta blockers are safe in terms of hyperkalemia and the AKI risk. It also has both renal and a cardiovascular benefit. Some beta blockers do not need dose adjustment like metoprolol, propranolol, labetalol, or carvedilol. Alpha blockers can cause hypotension and syncope, especially among with elderly population. Usage of alpha blockers alone causes more risk to heart failure, angina, and stroke. To reduce these adverse effects, we can add ACE inhibitor. For saying that, we have to use alpha blocker with ACE inhibitor to mitigate those adverse effects. Central acting drugs do not cause major adverse effect or significant interaction with other drugs. They don't cause reflex tachycardia also. Abrupt cessation after long-term use causes rebound sympathetic hyperactivation and causes sometimes malignant hypertension. Few words about vasodilators. Minoxidil is a potent vasodilator, but it causes sympathetic system activation and fluid retention. So it usually combined with the beta blockers and loop diuretics. If we choose minoxidil, we have to stop other antihypertensive drugs except beta blockers and the loop diuretics. It is not widely used drugs among clinicians. So if other antihypertensive drugs fail, we can try minoxidil-based therapy. What about Sglt2 inhibitor? They reduce the plasma volume, induce natriuresis, and glucose-induced osmotic diuresis. Although it is not an antihypertensive drug, it has antihypertensive properties. This declared timb study graph shows the reduction of both systolic and the diastolic blood pressure with Sglt2 inhibitor, and that effect is persisted up to 48 months. Sglt2 inhibitor helps to reduce uncontrolled nocturnal hypertension also. This is proven by a 24 ambulatory blood pressure study. So is it better than furosemide? Sglt2 inhibitor maintains extracellular water to total body water ratio better than loop diuretics and the vasopressin. Here, it maintains the ratio between the extracellular volume and the total body water ratio better than furosemide. There is a more total body water depletion when using loop diuretics. So, in patient with fluid retention, it decreases the extracellular volume. And in patients without fluid retention, it amelioration of the extracellular volume retention. So, ultimately, it prevent the overload or prevent the volume depletion. Or sometimes we can see there is a extracellular volume depletion at initial stage, but after 2-3 months, it comes back to normal. And ultimately, it reduces the heart failure and prevent persistent activation of the renin-angiotensin sympathetic system. My next topic is patient with dialysis. Among dialysis patients, it's difficult to maintain euvolemia. There is often overload risk and sometimes post hemodialysis hypovolemia. They have less intensive blood pressure targets than the normal CKD patients. Usual targets is between 130 to 40 by 90, not less than 120 by 80, as I mentioned previously. And there's some other problem is there is a intradialytic hypertension and the intradialytic hypotension episodes. Both episodes, they are closely related to the cardiovascular risk and the death. Several factors are contributing to lack of blood pressure control among dialysis patients. Most importantly, inadequate ultrafiltration due to limited resources. Other factors are non-compliance and the poor lifestyle pattern. As I mentioned earlier, erythropoietin causes hypertension by various mechanisms such as increased blood viscosity, increased blood volume, increased total peripheral resistance, and the loss of hypoxic vasodilation, and so on. Because of that, our anemia correction target also less than 13 gram per deciliter to limit the overuse of erythropoietin. Using loop diuretics have some mortality benefit among dialysis patients. It also reduces the hospitalization and intradialytic hypotensive episode. In this graph, I got from a study, and the hospitalization and the intradialytic hypotension are statistically significant. There is a benefit related to death, but this is not statistically significant. Few words about renal transplant and the hypertension. There are donor factors, recipient factor, graft dysfunction, outflow obstruction, renal artery stenosis, and the immunosuppression. As I illustrated here, 90% of the patients with calcineurin inhibitor have hypertension. Calcineurin inhibitors causes afferent arteriolar vasoconstriction, so dihydropyridines are used as a first-line antihypertensive drugs. We don't use non-dihydropyridine calcium channel blocker as it interferes with the calcineurin inhibitor metabolism. And tacrolimus is less risk than the cyclosporine. Chronic use of steroid also another risk factor, usually when it exceeds the 10 milligram per day in a cumulative dose. So we can use AC inhibitor and the AR blockers mainly for the cardio protection. So we can combine calcium channel blocker and the AC inhibitor at the first line therapy for a patient with renal transplant. So my take-home message is, if there is a possibility, if patient tolerate, try intensive blood pressure control, and it must be considered among CKD patients in your day-to-day practice and the clinic visit. The lifestyle modifications and oral medications are the cost-effective method to control the blood pressure. Thank you.
Thank you very much. Do we have any questions from the audience, please? May I ask a question about diet in this situation? You mentioned that red meat is bad and plant protein is good. Now, is fish a red meat or white meat? It's considered white meat, isn't it, if it's white fish or chicken? So what is the advice you will give to patients about animal protein as a whole? Is it just red meat that is bad, or is it animal protein? And more importantly, are there any randomized control trials comparing a plant low protein diet? I presume by plant low protein you are saying plant proteins instead of animal proteins.
Animal proteins.
And are there any trials comparing the outcome? Because it's theoretically it looks as if plant proteins are better.
Yes, this is a published very recent article, Lancet, last August.
It's an it's an RCT.
Actually, it's not just a theoretical statement.
Yes, that's my point. Is there an RCT comparing the diet?
So far, I couldn't aware of that, sir. But
because the recommendation is made quite strongly by people not to eat red meat and to preferentially use a plant protein by the nephrologists particularly. But my question is whether it's backed up by randomized control trial evidence.
So far, I couldn't come across any randomized control trial.
So should you advocate it at that point?
Usually the Sri Lankan people's diet actually not adequate protein diet.
Yes.
So even if average protein for a person is about 70 grams per day, that actually consists of probably 2 full egg and 1 egg yolk, white yolk, and there's a cup of milk with some plenty of dal and a large portion of the fish. That usually consists 70 grams.
So is that a recommended diet, or are you not recommending it? Are you saying to substitute the fish or say eggs with plant protein? Because plant protein is more expensive and difficult to
I encourage to take a fish and the plant protein compared to the animal protein, because
so the fish is more or less considered a plant, is it?
It's not that toxic as the other red meat like beef or pork.
But again, that's not backed by solid evidence, is it?
So they say there is a reaction with the gut microbiota with the red meat.
But there is no trial evidence, comparative evidence.
No.
We have another question, but the question has disappeared again. I just saw it. Yes. Is it recommended to use Sglt2 inhibitors for resistant BP control in CKD patients without diabetes?
The Sglt2 inhibitor actually have some antihypertensive properties.
No, I think what she's asking is if you are non-diabetic, would you use dapagliflozin or one of these things?
Still, guidelines did not recommend that. It actually has antihypertensive properties, but it is not listed as an antihypertensive drug so far. And this antihypertensive reduction also, it's between 8 to 10 millimeter mercury in the systolic blood pressure.
Was there a subgroup analysis of non-diabetic patients, or were there any non-diabetic patients included in the study?
No, I actually go through that 2 studies with a decliatimi, it's a diabetic patient, and there is a empagliflozin. Both are actually these conclusions made from the subgroups. There are no major head trials.
Right.
It's from the subgroups.
Okay, thank you very much, Dr. Mohanaruban. I think we have come to the end of the time allocated. Many thanks for your very, very interesting presentations. Both presentations were really interesting. We have some certificates to hand out to thank you for your participation. May I have Dr. Vithoosan and Dr. Mohanaruban both back on the stage, please? Dr. Vithoosan, thank you very much. Thank you. Very interesting. And Dr. Mohanaruban, thank you very much for coming and very interesting. I'd like to end by thanking a few people who were involved in this, the speakers, our judges, that's Dr. Professor Chandani Manikatunga and actually myself. Dr. Priyamali Jayasekara, who is the coordinator of this session, the Ceylon College of Physicians staff, the audiovisual team as always, Nalina and Impress Events, the staff for the ClinMark for their continued support, and to our sponsor, Cipla Pharmaceuticals.